Now is the time that everybody needs to come together.
Do we need to blow everything up and start again?
$113 million from our government.
And it's $1.8 billion over 4 years.
In the past, there's been competition between all of those models.
Even more historic than year by year.
And the quest for the right model, the model that works.
And there's urgency in this province.
Okay.
That was such a moment.
Yeah.
Go team.
Yeah, I like it. I am excited, very excited for this. I feel like this is a good thing for us to do. I could pinch myself because I'm here with three of our province's leaders, our country's leaders, because Ontario in a lot of ways leads the country. And that is just super exciting to me because there's nuanced, very specific skills and experience that you three have and others that you represent too. And people don't necessarily get to hear it enough, I think. And that's what we're doing here. I'm going to edit this, so this part's not going to make it to the actual episode. This is just us kind of like laying the table as what we're going for.
It should. You're doing fantastic.
Okay,
right?
well, maybe with that encouragement, I will reconsider.
And there's urgency in this province.
Yes.
We need to go now.
Yeah, there is urgency. So I don't necessarily want to wait till conference season to have these conversations. I want to have them right now, here today.
And some of the conversations that we're having behind the scenes, why not have them in forums like this so people can see how leaders in healthcare are thinking about it and help shape what that looks like.
I agree. So if we were at the conference right now and we were to go, and it's lunchtime right now, so we would be going to the buffet line. And if we were to bump into each other at that buffet line and said, hey, let's go, what are you doing? Where are you going next? Do you want to grab a bite to eat? And we went down to sit, what would we be bringing up? What topic would we be talking about right now? I'd have to say it's the record investment, $213 million from our government, and the deployment of that.
Yeah, and it's $1.8 billion over 4 years, right?
Right.
That's the headline topic. So it's even more historic than kind of the year by year funding that we know sometimes comes up piecemeal in our healthcare system. So how do we seize that and build something special?
Right, because the 1.8, any number is just a number, right? And that's significant, but it's almost like the fuel for the car. It's not the actual destination.
Yeah.
So where are we going? What do we want to see with this? What is happening on the ground? What is already working that maybe people don't know about? That happens a lot, where there's pockets of success, but it doesn't necessarily get amplified and echoed the way that we would want it. Kimberley, let's start with you.
I think one of the questions we have to ask is, do we need to blow everything up and start again? Or do we build off of things that already exist that we can amplify, we can improve, we can do a better job at connecting communities to actually meet the needs, not only of the community and the kinds of differing needs, because no one community is homogeneous. It needs something that can support all kinds of needs. And how do we support our healthcare workers to achieve that in a way that makes a difference and that all groups are feeling the impact? That's what I want to see. And not start from the beginning, but start from where we are today and grow and improve. How do we do that?
So we don't need to blow it up. You don't think?
No.
We can retool. We can reinforce because there's things that are working.
There's longitudinal relationships that are working in the community. Okay. Many of those healthcare workers need some supports wrapped around them to have even more reach and to still honor the valued relationship that I'm hearing our primary care workers and team members, they want to maintain, but they need some help. They're burning out. And we've talked before about the opportunity to look at things like joy in work and how do you understand what people are feeling today in the system, and then what do we need to do to improve it? That's where the art of the possible is to me right now. Sarah, I wonder if you could talk a bit about kind of the legacy that we've seen in this province of that whole person connection and thinking about communities and all the components that make communities strong.
Yeah, I think that if we were to, I might take that a little bit in a different direction, but I think that the province, and I agree with you, Kimberly, I think we have to absolutely work with what we have. I think that there's some brilliant examples throughout the province, and whether that be in rural, remote northern areas or in urban centers or urban adjacent, whatever that may be. And we know that community needs are different in every instance. And I think that there are different models of care. We have an alphabet soup of teams, CHCs, nurse practitioner-led clinics, Indigenous primary healthcare organizations, family health teams, community family health teams, others that don't have a name but are working. We have all kinds of practitioners or healthcare workers, right, working in solo practices or working in groups or working in FOs. And I think now is the time that everybody needs to come together. And I think in the past there's been probably unintentionally competition between all of those models and the quest for the right model, the model that works. And I actually believe that all the models work for different people in communities, for different parts of the province and different parts of a geographic region, which is what we're heading towards under the leadership of Dr. Jane Philpott. And those models, now's the time to bring everybody together, to collaborate, to figure out how then do we think about attachment, but also health equity. We know that there are people in the province that face barriers to access and traditionally have had poorer outcomes. And so how do we work together figuring out an inventory of assets of all those different models, all those different healthcare worker types, figure out who can see whom for what, when. It's also not a static thing. People need different levels of care at different parts of their life, and they might need intense care right now and maybe not later, or vice versa. So it can't be a one and done. We'll collaborate once and we'll figure it out. This has to be a new way of looking at primary care. I think for a long time we've been looking at vertical integration between primary care and other parts of the system, and that is important. But now's the time to bring primary care models, many of whom have not chatted with each other because they see each other as we're better than them, or we're different than them, or we don't serve the same people as them. And we now are seeing that people are coming together and figuring out how to serve communities of people in a different kind of way. And with that, we need to think about health equity, health promotion, attachment for sure. But I think if we just focus on the attachment, and we also need to think about which of those models can also provide the preventative care and the upstream supports and the social determinants of health supports, which means housing and poverty reduction and all of the things that will help the whole population be healthier with better health outcomes.
So there's not exactly one model that's the answer.
I don't think so. I think there is a model that is the answer for a particular person at a particular time. And I think that there's a model out there, and there is a healthcare worker type out there for all those folks, but we have to come together to figure out how to distribute the population on a geographical region for sure, but also a population region. So Francophones in Ontario, we have strong Francophone organizations. Let's expand them to make sure that every person who wants to access care in French can, and every practitioner that wants to practice in French can as well. So I think those are the pieces that we have to structurally think about different.
There's a chance to do that right now, it seems. There's an EOI out right now. I know there's not that much time to do that EOI, I've heard. So you're busy. All the organizations, all the funded partners are busy, and the docs are part of that conversation too, because every organization can't move forward without the support of the clinician leadership. And it really takes a village, right? None of these EOIs happen. None of these expansions happen without someone like you, Kimberly, who was taking a concept and making it roll out on the ground. And it doesn't happen without someone like you, Sarah, who's bringing awareness to said model. And it doesn't happen without our clinicians and clinician leaders, clinical champions. What do not that you speak for every single clinician, I don't expect that, Dom, but you do talk to a lot of people, and you do get a lot of information. You cross-pollinate across our province that information, right? So I would like to know what you would like to see out of this expansion.
Yeah, and to be clear, a few days left in the role of president at the Ontario Medical Association.
Congratulations.
Thank you. And it's been a wild ride, and I make a point when I go to events to stand by the front and welcome people, and then also hear their stories, right? And I've met with over 8,000 doctors.
Wow.
At this point, thousands
That's
more.
incredible.
Thank you. And thousands more team members, other health professionals, folks that are working hard in leadership, and then also on the front lines of our healthcare system. And I'm hearing two things. The first is that people want. At this point, thousands
That's
more.
incredible.
Thank you. And thousands more team members, other health professionals, folks that are working hard in leadership, and then also on the front lines of our healthcare system. And I'm hearing two things. The first is that people want to work in teams. Gone are the days of solo practice, any health professional, right? It's about teamwork. That's how we spread and scale a connection to a family practice, a primary care team for every single person in this province. And that's how we make something historic from this $1.8 billion over the next few years. That's number one. Teamwork is how we get there. Number two, even as we're building out teams, those relationships are going to be really important. So we did a study a few years ago on why does it matter that people have a relationship with their family doctor or primary care professional.
Right.
Why does it actually why does it matter? We know that it does.
Yeah.
We know that there are health system savings, they get better cancer screening, they use the hospitals less often, save emergency rooms for the people who need them.
Yeah.
Why does it actually matter? And we showed that actually it matters because people feel like they're more involved in their care. They're getting care from someone who sees them, their values, and as a human being. They're more confident in the care. And because of that, they're less likely to feel like they need to use other, more expensive health system resources that may not be needed. And on the flip side, for the doctors, health professionals, that relationship builds joy in work. There's something,
Yeah, for sure.
I'm a family doctor myself. There's something so special about caring for that human being in front of you. That's the secret of family medicine. And that's also the secret of how we do really good care for people across the province as we're building out teams. Because healthcare it's caring for human beings should be a joyful endeavor.
Yeah.
Can I take that sort of one step further and think about sort of the history of how we got here? And this might be a little bit provocative, but I think that for a long time, and why this $1.8 billion investment is so substantive, is that we have been and I strongly believe, obviously we need the acute care system, 100% it is part of the continuum of care. But it feels like for so long we have been about dealing with the crisis instead of thinking about investments in preventing the crisis, the healthcare crisis and the health outcomes that are poor. The investment of $1.8 billion has put us in a place where we can actually truly see primary care as the foundation. And across the world, where primary care is that foundational piece and is invested in and supported and is the center cornerstone of the health system, that's where populations have the best outcomes. And I think we can glimpse it now. I think that, I work with decision makers a lot in my provincial role, and we're hearing them talk about primary care as a foundation, where when I started in this role a few years ago, it wasn't talked about in that kind of way. And so I think if we're thinking about integrated care, and this government has been on a journey towards integrated care, and again, everywhere around the world that is doing this are seeing better health outcomes. Not easy, no overnight fixes, and it's all relational, as we've been talking about. But I do think that there's an opportunity, and I think part of that is thinking about joy in work, but also fair compensation for fair work. And I think that when we think about the different parts of our health system and social sector, primary care workers, and are not often compensated at the same levels of other places. And I think we have to think in an HHR crisis, a health human resource crisis, compensation, and then also all of the other pieces around what brings somebody meaning to come to work. But people also need to be able to put food on the table and pay their rent and their mortgages. So I think that that's a piece of it. And I do know that decision makers are talking about that. And I know it's on their radar, but it is a component that could be a risk to this $213 million for this year if we don't address it in a good way, because we won't be able to recruit folks or keep the folks we have that are already working in primary health care.
People who are working in primary care deserve to feel valued.
Yes.
Feeling valued is a big part of joy in work, and people in primary care deserve to feel valued.
Yeah.
And so many of the workers in the primary care space love what they do.
Yes.
Yeah.
They want those longitudinal relationships. They want the upstream work. They believe in what the difference they can make to avoid some of the bigger healthcare crisis for people because of those relationships. But it needs to start now.
Is that part of the problem, that the people in primary care do love it so much, that they are valued and principled? I'm going to steel man the ministry perspective for a second here. Why would we increase the salaries if people aren't leaving?
But people are.
People are, yeah.
People are.
Yeah.
They are leaving. We have a recruitment and retention crisis right now in primary care. And they're leaving to go and work in hospital systems that are paid a lot more, sometimes $20,000 to $40,000 more per year. And I think that what's happening is that it's this weird misconception, this myth, I think, that community care is easier than hospital care. Hospital care requires a different kind of skill set. But I think in the hospital, they have a whole team of people and infrastructure, and often in community, you're the only person in that moment, providing that care with people in real crisis. People are coming to primary care in a different level of, social complexity and complex health comorbidities. Like it's not, and there's no resources. And for many, there's no teams, which we're trying to fix with this funding. And so I think that there's this misconception that people in hospitals should get paid more for what they do. But we're hearing that people go to hospital and it's easier for them. They've done and they walk away, and they don't have the stress of what they had in the community. But we also, and I've been around for a long time, and we have people that would say, I want to stay here. I know I get paid less, but I can do the work I love. My values align with what I'm doing. I can be comfortable. I don't have to be something that I'm not. I can live and breathe my values at work. But now people are literally, I'm hearing from executive directors and CEOs of our member centers, people are coming into their offices crying, saying, I don't want to leave, but $30,000 more a year, I can put my kids in hockey.
You have no choice at some point.
Exactly. So it's too much. The gap now is too much. So we got to close that gap.
And by the way, that applies for team members in primary care teams. And then also when I'm meeting with medical students, residents,
Yes.
they're not seeing family practice as a viable career choice
Yes.
anymore.
And so people are leaving, for sure. The new EOI doesn't have anything that addresses pay equity in it for people in the community. So it's an exercise of expanding, but not reinforcing the people that are still there. So that reminds me of like Jenga, kind of. Are we kind of playing Jenga here and seeing how many bricks we can stack on top before the structure gets wobbly? I mean, like, nobody disagrees that primary care, from the patient to anyone working in the healthcare system, even people who can't say that people deserve raises, formally in a side chat at a conference, they'll probably address that it's ridiculous. So I think everybody knows that it's kind of ridiculous, and it doesn't address it here. So I don't expect anyone to say anything. I just want to say it again. We do need to increase the wages of the people working at these organizations for the sake of all of us, the sake of our future, us in the future, our families. We all get our health care here.
And by the way, could I try a concept with the team here? So I think of this concept of gravity when I think of recruitment and retention of health professionals, doctors, nurses, other team members. Gravity is that front desk team member who's been there for 20 years. Gravity is that doctor who's been in practice for years and years and now mentors other doctors, nurses in their practice. Gravity is that team member who's been around, that link worker who knows their community so well, that acts as a resource for the other team members at their clinic. Gravity is valuing those people who have been there, who are there now, keeping them intentionally and working on retention. And by doing that, you actually pull people in, you invite people into our clinics and create a system where more people feel pulled towards primary care. So we're not going to recruit our way out of this. Actually, we need to work on that gravity and the people who are already there, already loving the work, to bring people in.
And there's a way that we can, I'm going to be Switzerland. How do you kind of come through the middle? If we value the healthcare workers and allow them to do what they love every day, how do we create the system in a way that actually creates value somewhere else that then can be reinvested? If at maturity we're properly supporting primary care connection over the longitudinal relationship, look at what the dollars can be saved in other parts of the system.
Yeah.
That can be reinvested into providing this balance that needs to keep our healthcare workers where they want to be, making the difference for the community, and actually supporting better primary care, whole attachment and care delivery. That's what I think we need to fight for, and this is our opportunity. I could be Pollyanna. I go after a lot of things, and the hard implementation of taking these concepts is what we need to test right now. And it's, to Sarah's point, it isn't about which model. It's actually about how do the models work together for the right kind of neighborhood environment that does meet all of the different needs. And whether that's one digital front door, a physical front door of a clinic that really supports, isn't lineups for hours, but is, hey, come one, come all. We will make sure that you're seen and get matched to where the primary care connection and team is best suited to your needs, by your location, by your physical status, by your social determinants of health status, and by your chronic disease status. Let's get the right mix, not just having anybody attached anywhere, but the right attachment, I think, is what we want to fight for.
I think that is the key right now. I think that is absolutely where we need to go, because I'm a bit worried that if we just focus on the widgets, on the numbers of attachment, that people can be attached, but they might not be attached to the right person. If they're Indigenous and not attached to an Indigenous primary healthcare organization, the likelihood of them going and seeking care in a safe way is not high. But they're attached. And so that's good. We've done our job. And I don't think anybody in decision makers want that either. But I think we have to do this the right way. And I feel worried, and I understand people need primary care right this second. But I also think we need to do this the right way and build on the models of success like yours, Kimberley. And because I think that if we go just fast, we'll get somewhere, but it might not be the place we want to be in the end. And I think we're going to leave people behind. And so I think we have to sort of manage that in a way. And I think that that's why building on the models that exist, working collaboratively, I've heard so much through this province and through this process that it's a lot of folks coming together to create net new. And they're going to create a whole new organization and start attaching by May, whatever, July, whatever, October, whatever the money gets in. That it just doesn't feel like the right approach. I think that we need to be thinking about how do we do it in the way that you're saying. And I think the other thing around it is that we can do this without competition. I think there's some unintentional things that have happened through this process, where I wish that the front of the application and the proposal, and I've gone through it and everybody has, but I wish that the proposal, the top thing was name your collaborators and talk about how you're going to collaborate. And instead it was like, who's going to be the lead organization? Right. And I think decision makers think the lead organization is just the fund holder and they'll coordinate. But I think people read that as who's going to come out on top as far as the team that's going to get the money. And I don't think that's what we need. And I don't think that that was the intent. But I think that I just wish that this was more framed as how are people working together and what's that going to do for your population? And then down on page 6, say who's going to be the fund holder out of the 4 models. That would be,
Just
I
rearrange
think,
the
I think something as simple as that would put a different emphasis on that. And I think the centralized intake to match to the right teams, let's build that into the form as well. How is that going to happen?
Yeah.
So that we're matching, as you say, you said it beautifully, but I'm going to restate it, the right person with the right primary healthcare worker and associated team.
And just a lived experience of that. We're live writing a proposal that's still getting penned. Got 4 days left to go. But that is strong collaboration of 85 primary care leaders coming together to say, okay, I'm willing to be in on this because it's about the greater good rather than my own practice. But that takes collaboration, that takes trust, that takes all those things.
But that's not happening across the province.
Right. But it needs to happen.
Yes,
This is
exactly.
the only way to work out of this. The other thing I would ask, Dom, is your perspective on there is a fine line right now of we could do some of this. I believe in Ontario we can do this with the right leadership, the right approach, all these things. And learning as we go. We're going to make some mistakes, but let's be willing to take some risks and learn. But if, to your point, Sarah, if we go too fast, not only may we mess it up, we also are going to lose some more clinicians or healthcare workers working alongside us. Even willing leaders within the network that we've created have said openly, this is great, but I'm not just attaching more if there isn't a return on investment to support me better, to support the patient and the community that I want to have that longitudinal relationship with. So we have to be very careful, to your point. This isn't just widgets. It's not just numbers. It is that whole support.
Yeah.
And the time is now for us to show our healthcare worker members that we will do that support for them as much as we're supporting the community. Fine line, and we got a few months to start proving that, because otherwise the risks, I think, are pretty high.
That deserves a mic drop. That's perfect.
Don't actually drop the mic. I'm just kidding. Those are expensive. I'm just kidding. Go ahead.
Two thoughts on that. One, just hearing you, Kimberley, the power of role modeling, right? And in that value set. And, even that mindset of, I'm OMA president. Right now, I happen to be OMA president, and I believe in a stronger healthcare system. But I happen to be doing it through the work of the OMA. You happen to have your role. You have that same set of values. You happen to be working through a different organization, but the value sets line up. Same with you, Sarah. I think there are opportunities to role model that and go beyond the organization by organization lens and come at this from this sense of shared values, just like what you're doing, where you have dozens, almost 100 organizations, teams coming together and saying, look, we're all part of different teams, but we believe what you all believe, and let's get there together. Second thought, you're totally right in that when I'm meeting with doctors, with health professionals all around the province, they're feeling stretched. They're feeling so stretched already at baseline. And on top of that, we haven't seen anything yet. Next few years, we saw the Ontario Hospital Association and Dalla School of Public Health projections. Our population is going to be older, more complex, living longer, sicker. Our healthcare needs are going to explode, and plus social determinants on top of that. So that means we're going to have waves that hit our healthcare system even harder than it's being hit right now. What does that mean for attachment? What does it mean for realism and how we support the human beings? Now we support this model where everyone is connected.
Talked a lot about attachment, and I think absolutely important, but we also have to talk about access. And I think thinking about, I know that my friend in rural Ontario is attached, but she has to make an appointment 6 months ahead on a regular basis to actually get access, because this poor clinician, poor healthcare worker just has so many people and doesn't have enough time, right? And getting an appointment for an urgent issue, she can't do. And this is the way to resolve this situation. But I think we need to talk about what is the team members that can help with that. And I think we need to talk about scope of practice. I think we need to think about the important role that nurse practitioners play. And if nurse practitioners are working to full scope, they have their own roster of folks that they're serving and serving quite well. If we think about link workers and social prescribing, we did an evaluation of the link worker role within a team. And for physicians that have complex folks that are coming to them really regularly, if they are attached to a link worker to help them navigate the social determinants of health and navigate things like food security and social isolation and other types of things that have been bringing them to see the physician, that physician will see them 40% less. So that is a significant savings of time for that clinician doing things that really, is that the best use of a physician's time when somebody's feeling socially isolated and they come in for a visit, right? So I think that, and I'm not trying to belittle the person coming in at all, I understand, but I think that there are specific team members and intake processes. I think adapting and embracing a learning health system model where we think about the data and the information that we have available and using that data in real time to improve how folks are seeing intake models, access, how do we ensure that people have good processes to match with the right person at the right time. Like there's all kinds of different approaches, learning collaboratives, things, but we got to make the space for people to participate that. And we have to build the team around so people can participate in those things because they take time. But the rewards mean that people can see more people. And people who have burnt out can have a work-life balance. So I think that those are some things that we just have to think about. And I'm probably missing team members. I'm missing health promoters. I'm missing community development workers that can change the health status of a whole community if you address the housing situation or if you address harm, whatever that might be. I think there's a whole bunch of members of the team that can help facilitate that attachment and that joy in work for the primary care health worker that is at the heart of what we're seeing right now.
And Sarah, it comes back to the valuing of each and every healthcare worker in the team. And so that example is exactly what we're living right now. Many of the clinicians in our network are willing to attach more, want to attach more, but they need those supports. And they haven't had them before. So they would like to see a full scope nurse practitioner part of their team to work collaboratively. It isn't the competition piece, it is about how do we work together. But they also know that we need a bit of support. We never had that before.
Right.
How would I do that? And so we're investing in interprofessional education to support that ability to learn how to work together and go to maximum scopes of practice. That's critical right now.
Can I follow up on that just to dig in that? We have about 8 minutes left, and Dom, you got a lot more doctors to see. You only got 5 days left in your role, so you got a lot of places to be. We've got to let you go. But I would like to dig into that a little more. What does that look like? Interprofessional education. From me, I'm a former director, practice manager. I agree with you. What you said earlier is that I get the impression that government kind of strokes a check and rewards the money and expects results right away. I kind of got that impression on the ground. But that's not the way it is, because there's actual humans who don't know each other, who all have individual disciplines and colleges that they report to, all these different governance structures, oversight structures, really inherently not designed to kind of have their own lanes and pull in different directions. What is interprofessional education? I understand it's an intuitive title. We educate our clinicians how to be clinicians in their respective scopes, but then they come into the community and they will have to learn how to work with all these other individuals. I imagine that's kind of what you're talking about. How do we help with that so it doesn't take years and years and years to work and find a way to work together? Because it does take years and years and years from what I from what I've heard from the people who invested all that time years and years and years ago.
So I don't have the full magic on this, but what I would say is working to understand each other's skills and competencies in a team is really important. And part of understanding interprofessional working approaches is to hear those different scopes. Here, well, I was trained like X, and this is where I feel comfortable. This is how I know how to support a patient or a situation. One of the best lessons in my career, I've been in the healthcare space a long time, was when we worked as one team around a set of goals for an individual, and we didn't trip over each other. We had a bit of a key worker leadership piece. So if the issues were more related to a physio issue and mobility, and somebody's goals were, I want to get to my grandson's baseball game after a stroke, it is understanding who's going to take a bit of the leadership and how far their scope will go and where the other team members can come in and out. There are many more experts that can talk to this, but for us, it's imperative to make sure we maximize the value of the healthcare workers in the team and be able to utilize everybody's information and support to the best value.
Can I say something around that? Right now, we have this window of opportunity to build meaningful teams, exactly what how Kimberley is sharing. I think the misunderstanding that sometimes comes up in teamwork is just because you co-locate people, that they'll be working as a team, right? Actually, it takes work. It takes meaningful ideas, sharing, that sense of understanding. Building of trust. I think of the importance of link workers built into practices and how that takes building trust, and then it's such a benefit to that team. Doctor, nurse practitioner dyads, that model, I'm a big fan of that. That takes trust building and mentorship relationships and role modeling. What does that actually look like? How do you lean on each other? Right? So it actually takes intentional building of teamwork, not just co-location.
You got to go through the bumps together.
Yeah,
right?
Exactly.
You have to figure it out together.
And I think you talked about role modeling, and I think that's where teams that are already in this space, I think could be role models for teams that are like dipping their toe into it and figuring it out. And if I know, if there's one thing in my career of working with physicians, if a physician hears from another physician that it could work, then I think that that's a helpful, more meaningful endorsement that maybe I'll try this then if it could make it better for me. There's one thing that I think that we've just missed a little bit, and I think that is the patient voice and the community voice. And I think that we have to, while we navigate this and we think about provider needs and we think about the healthcare worker in this, we also need to center, I think, the voice of the community and the patient. And I think that if we leave them out of the design process, we may end up in a place where the services, the care isn't as meaningful or impactful as it could be. So I think thinking about things like community governance, thinking about things like co-design, thinking about client engagement surveys, thinking about tools like PREMS and PROMs, and thinking about patient-reported outcome measures and things like that, I think is how we can combine the needs of like the healthcare worker with the needs of the people that we're designing all these services for.
Yeah, fully. In our prep for this work, we went to the Healthcare Connect waitlist and were able to ask individuals on that waitlist, what is important to you and how do you want to be best connected? Sometimes we overcomplicate the solution. They want some very basic things. So we have to your point, Sarah, we have to listen to that voice and have them co-design this before we get too falutin in a solution.
There's a practical way that OHTs and teams can do this. We know about dyad leadership, so clinician and health administrative leader, so the operational leader. So that's dyad leadership. Triad leadership, right? So clinician, health operational leader, CEO, and then lived experience leadership, right? So that's the new era of how we're leading teams.
Yeah, and I think that I love that you use the language of lived experience, because I think we have tried to do this in the past where we've centered patient voices. And I think that what I've seen, and not in every case, but in a lot of cases, the patient partner or family caregiver is also, again, someone that looks like me that can navigate the health system or is a retired health professional and is now doing this but had a mom with cancer. And I think we have to be reaching the people that face the most barriers and the worst health outcomes and provide them tools and supports and funding to be able to participate in that design. Because I think if we solve the system for their needs, then everybody's needs will get met. We need to sort of think about who's at the table in that triad.
And when we get to the point of there's dollars on the table, there's some big decisions that are going to be made in the next several months, there may need to be a disproportionate allocation of some of those funds to properly support the communities that are going to do exactly what Sarah said. Focus on the most complex people that have the less access to care, support them first, and the rest of the system will benefit.
I could do this for 2 hours, by the way, with you. We got to go. You got an EOI to do. You have.
I got some stuff to do too.
Do you have some? Okay. Sarah's got stuff, and I know Dom's got to hit the road for Hamilton. Okay. Thank you so much. It's been such a pleasure.
Yeah, thank
Okay.
you.
The group.
I love it. Okay.
Yay!
Ontario.